All right, thanks everyone. Hope you enjoyed the St. Patty's Day music. Everyone's getting ready for St. Patrick's Day. So let's go ahead and get started for today. So welcome everyone to the Society of Thoracic Surgeons Congenital Heart Surgery Database monthly webinar. Today is Tuesday, March the 15th. So thank you everyone for joining. Let's see here who we have on the call from the panelist side. From the STS, we have myself. Carol is out today, so it's just myself and Chastity from the core group and our CHSD consultant. And we also have Dr. Ram Subramanian on from our surgeon leadership. Our IQVIA team, we have Joe, Melanie, Jean, Case, Madri. I think that's it from the IQVIA team. And I also see Leslie is joining us on the panelist side as well. So thank you everyone for joining today. Per usual, I'm just going to start with my STS updates, and then I'll turn things over to Chastity for STS education. Today, she's going to cover all things harvest, as we have the harvest close coming up. I think the 1st of April the 8th, I believe. And I don't think we're going to have another monthly webinar. We're not going to have another webinar prior to then. So we wanted to go ahead and give Chastity the opportunity to cover harvest closing tips, getting ready for harvest close. So she will go over that. And then we'll turn things over to IQVIA for our IQVIA update. And then, as always, we will finish with our questions. If you have questions, please be sure to put those into the Q&A, not the chat box. I'm kind of flying solo here on the STS side, so I can't monitor both. So if you could, again, please put your questions into the Q&A box. I greatly appreciate that. That way we can also keep track of the questions and record those as needed. All right, so let's go ahead and hop into things for today. Our STS updates, the March training manual is available and has been posted out on the STS website for your review. As requested, I have gone in and updated the analysis overview to include the new exception rules to the primary procedure determination. So the updated analysis overview has been posted in the IQVIA library. As well as I have also updated the single document that is posted out on the STS website, updated rules to determine primary procedure. So again, the rules have been updated and posted within both locations, again, within the IQVIA library and within the STS website. If you have any issues locating that, please feel free to email me and I can point you to them. Our 2021 harvest update analysis results expected, we have said, are expected to be available mid-March. IQVIA is continuing to work on those results and get those out. So those will be coming soon, coming very, very soon. An official STS notification will be sent when those reports are available to you. So hopefully, again, that'll be coming very soon and an official notification will be sent. Spring 22 harvest update, again, as we just mentioned, the official communication about the harvest close was sent back on February the 18th. The spring harvest close date has been pushed back again to April the 8th. And the last date to opt out is April the 12th. Our fall 22 harvest is scheduled to close September 16th with an opt-out date scheduled for September the 20th. All right, additional STS updates from myself. The 6.22 data version upgrade. As you all are aware, the data specs and the software specs have finally been released and shared to all the vendors. We did have our STS vendor call last week. That was a very productive call, and we are going back to STS surgeon leadership with all of their feedback. So the go live date for version 6.22 is currently under review, and it will be discussed at our March task force call. I believe that is scheduled for next week. So more information will be coming to you all, as well as to the vendors and everyone regarding the go live date for version 6.22. In the meantime, our upgrade webinars will continue. Our next webinar is scheduled for March 22nd at 12 p.m. Central, and we will start with other cardiac procedures and work our way into the aorta section. Also, some of you have noticed, if you have not heard about this, we are having a surgeon upgrade webinar. Many of you asked for this to have a specific webinar for our surgeons. It will be moderated by Drs. Jen Nelson and Dr. Ram Subramanian. The surgeon webinar is this week. It is Thursday, March 17th at 7 p.m. Eastern, 6 p.m. Central. And again, here's information, a snapshot on the screen of the STS webinar series. This information is listed on our STS calendar of events under our meetings tab, and also listed on our STS National Database webinars page. So our STS marketing team has done a phenomenal job marketing this to our CHSD community, to our surgeons. So please share this information with your surgeons. Of course, anyone is welcome to attend, but again, this upgrade is geared towards our surgeons, and we will be discussing the new stat scores, the new upgrade, and the upgrade, as well as the adults with congenital heart disease component. So again, please encourage your surgeons to attend. If you're not able to attend, this webinar will be recorded and will be available to be reviewed out on the STS website. All right. That's all I have from STS. I'm going to turn things over to Chastity so she can cover everything about the data harvest. So Chastity, the floor is yours.
Okay, thank you very much, Leanne. And I see that you already answered the 2 questions that were in the chat about the surgeon webinar on Thursday being recorded. And yes, it will be recorded. So thank you. It takes care of those first 2 questions. So today we're going to just talk a little bit about the tools that make us successful for harvest. This is really a back to the basics. So I know it may be a repeat for those of you who have been doing this for a little while, but I think there's always something for us to learn. And I know even when I put these slides together, I always learn things. And so it's just a time to share some, I think, success steps and tips, and hopefully help you organize as you should be already have started your harvest process. For those of you that are new, you may want some more detail regarding these steps and things. And so you're more than welcome to reach out to, I know for sure, Leslie and Leanne and I, but anyone on the core group would be happy to help you if you have some more specific questions. So we're going to go over a little bit about missing data, as well as some data validation for data accuracy, and then just share some tips along the way. So next slide, Leanne. So there are really 2 steps to harvest, and this is completing your local data set for your analytic window. You know that analytic window at STS is 4 years. So for us, this is the surgical dates that are occurring between January 1st of 2018 through 12/31 of 2021. So you're going to complete this data set within your software, and then of course we upload it to IQVIA and we say, woo, we're done. And so it sounds so simple, but we know that there are a lot of steps here that we need to complete to make sure that our data is complete and that our data is accurate, so that we can use this data both locally as well as nationally at the STS level. So next slide. So within these 2 steps of completing your local data set, as well as uploading your data to IQVIA, you have multiple places where you can stop, clean up data, validate your data before you upload it. So you can do this locally with your own software, and many of our vendors offer tools to do this, as well as IQVIA offers tools to do this. So you have to come up with a plan that works for you. Personally, I work within my software quite a bit, quite often, before I upload to IQVIA, and IQVIA is somewhat serves as an extra check, a double check, other validation tools that they have that my software doesn't have. And so I kind of work between the 2. You have to come up with a plan that works for you. Next slide. So really, harvest is a continuous process. The tools are designed for you to use them continuously. So you don't have to wait until STS announces the harvest close date of April 8th to suddenly say, gosh, I don't have that much time before I need to be cleaning up my data. You can clean up your data as often as you want. So come up with a plan. Is this something that you want to do monthly, quarterly? Whatever works, so that you're meeting that harvest deadline. You don't want to wait until these final few weeks to suddenly discover perhaps there is an error in your software that you need to work with your vendor with, or something along those lines. Perhaps you've coded something incorrectly, not the time when you're down to crunch time, right? And so if you do this continuously in a schedule that works for you, you will be more successful. And so it's really a continuous process of cleaning up your data, uploading to the IQVIA platform, again, cleaning up data or validating your data, and again, reloading to the IQVIA platform. And when you're doing this, you're going to eventually have all 4 years of data that are in that platform that you have validated. If you do this continuously and in small chunks, then you don't have as much to do at the end. Next slide. So what is meant by data cleanup when I say that? So really, I would say largely in the STS database, you're identifying your missing data, and then you're also validating your data for accuracy. Next. And just a good point to say, if your data is inaccurate, it's useless. We can't benchmark against other programs. We can't do any research or local QI work if your data isn't accurate. Next slide. So let's start with identifying our missing data. Now, of course, all of our software vendors offer tools for, identifying missing data. I'm only going to use what IQVIA reports are available for this, since all of our software works differently. And so I can't tell you what your vendor offers, but what I can tell you is what IQVIA offers to all of us. So if you go into operational reports, I've listed all the reports here, and you see right at the top, there's a report called the missing variable report. When you select on this, you're going to enter a date range. And so again, you can work in small chunks of data and say, gosh, I've just uploaded 1 year of data. I want to work within that 1 year. Maybe you've uploaded all 4 years of data and you want to look at it, completely. Where am I at for all 4 years of data today? So eventually you have to get through all 4 years of data and validate that, but you can pick your dates that you'd like to work in so that you can take in smaller chunks of data. Then you also get to select if you want all operations or index operations only. Now we know the index operations are what are analyzed in the database. So you can start there, but I would always advise going back and doing all operations just to make sure that your whole data set is as complete as possible and as accurate as possible. Next slide. So this is a screenshot after you've selected your date range and index or not. That will come up. And so this is a snapshot of my report. It's an old report, so don't pay attention to dates or anything, but I just had some snapshots that I can include here. What you see is a ton of missing data. Now, does this mean that I'm a bad data manager? No, it may mean that at the time this data was unavailable, I couldn't find it, I missed it on accident, whatever. And so I've got to go line by line and figure out what I'm able to collect, really. But you want to prioritize this work. I'm not going to start with things that may be less important in the analysis. I'm going to start with what would preclude me from being included in the analysis. And so I'm going to start with the fields that are required for mortality analysis or the case mix models, benchmark operations, and lesion specific operations, and work my way down through that list and then into things that might have less bearing on the analysis. So if we start, there are filters on the left-hand side that you can select. If you see under all, there is mortality. So that would be the mortality analysis, the anesthesia report, as well as the risk model. So you can select any of those and get to the fields that are missing for those 3 areas in your report. If you're not an anesthesia participant, you won't need to go to that anesthesia specific report. You can also then filter by op type 1 and 2, which is CPB, no CPB, cardiovascular, as well as then the other op types. So it's another way to prioritize the data. I, of course, would focus first on operation op types 1 and 2, and then go into the other op types. Okay, next slide. So here, when I select the mortality report on the left-hand side in the filter, you can see up top that in my missing variable summary, I have 4 cases that are not going to be included in the mortality analysis because I have some fields that are missing. And you can see that 1 case, I have a 30-day mortality status missing, and 3 other cases where mortality status at database discharge is missing. So then when I select those, that's why they're highlighted in blue there, I've selected them, they bring those 4 cases up in the case list down below. And now I can identify based on the op ID or patient ID who these patients are. I cannot update any information in the IQVIA portal. I have to go back to my software to update this information. So now I'm going back to my software and back to my electronic health record, or whatever methods that I'm going to use to employ to get this data. I don't want anybody missing from mortality analysis. We worked hard and I want it to reflect and have all patients here. So whatever I need to do locally to elicit this information. Sometimes what happens is these patients, perhaps database discharge, they went to another facility, and I need to call that facility and follow up and see if the patient finally has gone home, or if perhaps they hadn't had a 30-day follow-up visit yet. And I just needed to go and see if they've now followed up with somebody at our hospital, or perhaps I can follow up with their cardiologist if it's not at my hospital directly. So whatever methods I'm going to employ locally for completing this data, I then update that in my software. Now I have to go back and re-upload into IQVIA to see these changes. Next slide. You'll then you can go through the anesthesia as well as the risk models to see what other fields are then missing. So then there's another way in IQVIA that we can look at mortality missing data. And I really like this report as well. And this is called the Mortality Eligibility Summary Report. And so while it's really looking at eligibility for mortality, what you also will see is it'll highlight what is missing for you. So again, you enter a date range, and then you're going to use the filters on the left-hand side to identify which cases are ineligible for reporting. Next slide. So what you see here in the Mortality Eligibility Summary Report is it gives me by year, it identifies the number of ineligible cases for mortality reporting, and also gives me my percent missing by year. And this matters because we have to have less than 2% missing for surgeries that are after surgical year 2017 to be included in the mortality analysis. So you can see here I have, and of course this is not taken at the same time as that previous snapshot was, but I have one case who is missing or will not be included in the mortality analysis. It gives me a percent missing for surgical year 2018 of 0.23 and an overall 4-year total of 0.07% missing. So can I stop here? Sure. I'm below that 2% missing. Every time we'll go, and it's a 2018 case. I know this case is missing. I know I don't know exactly where this patient is, which is the problem. And I cannot find them, but I still look every time. I still reach out to their cardiologist every time, just hoping that I'm going to be able to figure out this patient's status. So when you look down below, you can see it checks the box for me that this patient's 30-day status is what is keeping this patient from being included in the mortality analysis. So again, these reports are only identifying what is missing or unknown. Unknown does count as missing. So it does not apply any logic that gets applied at the DCRI or analysis level. So if there's an exclusion to the analysis, so for example, if my 2018 missing case happened to be the 30-day status on a patient who underwent a neonatal pacemaker placement, that patient is excluded from mortality analysis, but that's not what this report is doing. This report is just saying, hey, this patient will be excluded or will be excluded based on your missing and that you don't have this patient's 30-day status. So if I were lucky and that's what this patient had done, no harm, no foul. But unfortunately, that's not what this patient had done. And so I really do want to find that 30-day status. But just remember, the analysis logic is not applied in these tables. It's really showing us what is unknown or what is missing and what we need to go after and work upon. Next slide. Okay, so just as a reminder, what are the fields that are required to be included in the mortality analysis? The date of admission, a date of surgery, an operation type, primary diagnosis, primary procedure, and then your mortality status fields at hospital discharge, at 30 days, and at database discharge. And a couple of things I'd like to point out is you have to have a primary diagnosis and primary procedure that are sometimes your software can point out you've selected something that can't be primary, let's say. And so you want to make sure that you have those solved on your local end. As far as op type, what gets included in the mortality analysis is only the index operation. And by definition, the index operation is the first CPB cardiovascular or no CPB cardiovascular operation of the episode of care. So you've got to have an op type within your episode of care that matches that. Your date of surgery has to be within that 4-year analytic window that's being looked at by this analysis. And then of course you have to have a date of admission. So if any of these are missing, your case will be excluded from any mortality analysis. So this is throughout the entire report that we get back. Anywhere where there would be a mortality analysis, you would be excluded if your patient didn't have one of these fields. So a good example here is I have a patient that discharged to long-term care. I then have, a hospital discharge status that's filled out. I may have a 30-day status that's filled out, but I won't have a database discharge date until that patient lives in long-term care for the 6-month period, dies or goes home. And so that field remains empty. So that case will not be analyzed until I have a date of data or a status at database discharge completed. So also to remember here is if you have greater than 2% missing per year of these fields in your data file as a whole, you as a participant will be excluded from the mortality analysis. So that's where that 2% really comes into importance, and we have to pay attention to it. This is all spelled out in detail in your IQVIA library report, the CHSD analysis overview that Leanne just spoke to, that she has updated it for the new analysis that's coming out. And this is specifically in the section of determination of case eligibility for inclusion in mortality analysis. So I urge you to go and get more detail from that report. Next slide. So these are the fields that are required for the risk model analysis. So this is our infamous table 16, as you know. And so you are required to have all of those mortality analysis fields, since table 16 is looking at operative mortality, but then also you have to have completed pre-op factors, chromosomal abnormalities, syndromes, your non-cardiac congenital anatomic abnormalities, your number of prior cardiothoracic operations, prematurity for neonates and infants, age, which really we're entering a date of birth, and then your software is calculating the age for some of you may be calculating an age based on who your vendor is, and then sex has to be male or female. So again, if greater than 10% of these are missing, the participant will be excluded from the model analysis, so no table 16. And for age and sex, male or female, those two fields are a little different. If these are missing, then the case is excluded from the analysis. So there's participant level exclusions as well as operative level exclusions to be in the risk model. So again, if I'm looking at missing fields, these are definitely places where I don't want any of these missing for a patient. Again, laid out in your IQVIA library in our analysis report overview. This is in the risk model specifications under inclusion criteria. In more detail, you'll find that in this report. That's my Yoda speak, apparently. Next slide. Okay, so missing data. We get lots of questions to the core group or just those of us on the side. How do I maintain organization and minimize rework? Every time I, re-upload data into IQVIA, now I have all these new reports to work through, and I get that. So for me, I have what's called, my right now is spring 2022 harvest worksheet is what I call it. And it's really more than a worksheet. It's about 50 worksheets all together in one Excel file, where I know every piece of information that I need to either validate, clean up, something is wrong with it, it's missing, whatever. And so I create this, and then as I update things, I update that spreadsheet. So I don't continue to go back and look for a field 5 times that is missing. I know that for whatever reason, we didn't document something, so I will never have that piece of data. And so instead of going back 5 times during this harvest, looking for that missing, if I update the spreadsheet to say it is missing forever, I will never have it, or I validated this is indeed the correct procedure and diagnosis, then I don't rework. And so that's what I do to remain organized. And again, reach out to other people who've been doing this a while. Everybody has their own kind of method to their madness. When you update data, in your local software, you always have to remember to re-upload it into IQVIA. And then remember, when you upload it, these updates will impact multiple reports within the IQVIA system. So if you had missing mortalities in your missing variable report, and you cleaned them up and re-uploaded, then those should also fall off that threshold report and no longer be ineligible cases. So just remembering that you'll see these updates throughout multiple tables. What if I cannot find the information to complete these fields? So again, no matter how good, compulsive, or crazy we are with our data, there are just some things that we just don't have access to. So no matter what, the missing thresholds will be applied upon analysis to those fields that are required. So always keeping that in mind, and that a case may be excluded, or in your entire data set, the entire participant may be excluded from analysis, which of course that is exactly what you don't want to happen. And so this is where you work throughout the year to work with your team to say, we are not very good at documenting this or that, or perhaps I need, someone to create something for me so that I can always get to this field. Perhaps I need help with 30-day follow-up and I need someone within the program to make phone calls to, outside cardiologists or pediatricians' offices and things like that. So start leaning on those people, start developing relationships with those people within your programs. Your surgeons do not want you to have missing data. And never would want a case, let alone your entire programmatic data, be excluded from an analysis. So I imagine they want to help you. And so it's really where you start, making those relationships. And, I kind of latch on to people like a leech and just say, help me. And usually most of the time people really do want to help you. They like that your center is doing well, and that, you give them some kudos for helping you. And so find those things now. You can't wait until 3 weeks before the end of harvest to suddenly start asking people for help. These are the kinds of things that if you're organized, and you have maybe an MA that works in your cardiac surgery program, and you say, hey, could you reach out to these 3 parents for me? I can't find them. They haven't followed up with their pediatrician. They were no-show to cardiology. Is there any way you could reach out to these 3 parents? And most of the time they'll do that for you if you can identify those people. And so again, just working within your program can't be done in the 3 weeks prior to harvest, but something to think about for upcoming harvest is creating those relationships. Okay, next slide. So tools for identifying data accuracy. There are many tools in the IQVIA platform to help us with this. So the primary procedure mismatch report, the harvest summary report, as well as the participant dashboard. I use this for data validation. Next slide. So the primary procedure mismatch report, most of you all should know this, but it identifies if your entered primary procedure is following the STS rules that are identifying the primary procedure. It is strongly recommended that you will update your procedures then to match this report. These rules do change over time, and so the primary procedure report may change over time as well. So as you know, with our new stat score implementation that is coming, the primary procedure report a mismatch report is currently being worked on. It's been beta tested and it's going to be rolled out here soon in time for our next harvest. And you're going to have some procedures that you need to change around. So knowing how to use this report will be really important. If you have questions about how to use it, please, again, feel free to reach out to Leanne, myself, Leslie, or anyone on the core group, and we'll be happy to help you. Next slide. So here's an example from the primary procedure mismatch report, and you can see from the surgical dates that I have 2 cases here that are in error per the rules. And so down below, when I select those cases, you can see what I selected as participant primary versus what the STS primary should be based on the rules. Now, the thing I would say here is these gave me pause. Why do we have a VSD repair patch coded along with a ventricular septal fenestration? So it didn't make sense. And so not only did this serve as I perhaps have something out of order that needs to be changed, I really need to reread this op note and see if this is what we should have entered and coded, and these were wrong actually. And so we redid the procedure. So my report is actually cleaned up. But not only does this report serve as a nice tool for identifying your mismatches, but it also then gave me pause to say, I use the long list. And so sometimes I can get really bogged down in the detail of the long list, and perhaps I miscode something and it maps to something it shouldn't, or something I don't want it to map to. And so that's where this report comes in handy almost for 2 things. Next slide. So the harvest summary report. So this is a really nice report that identifies your whole data file errors and warnings. And you can click on any part of the pie graph and see, you know, what you have in error or in a warning. And so it's really validations. Understanding though that within the warnings, it will also include missing data. So when I select, I was like, holy cow, how do I have, you know, 58% of my cases have an outstanding warning, or 68%. When I went to look, I can see that it included all of my missing data. So this number will decrease as my missing data decreases, but you can see by and large, my status at 365 days is what hasn't been completed. And so it gives me a place where I can focus. I also know that Mel with IQVIA wants to jump in here and give us a few more tips about using the harvest summary report.
Yeah, thanks, Chastity. Just a quick note in regards to the critical errors. I just want to make sure that everyone is aware that the critical errors do not currently appear on this report. This is only displaying your errors and warnings. So your critical errors are the errors that you encounter during the time of the upload, where basically it's preventing that data from coming into the database. So that information will, of course, appear at the time of when you're uploading. So that information, again, is not displayed in the harvest summary. We are looking at enhancing the report to include those so that it gives you that additional information, but just wanted to let you all know of that information. Thanks, Chastity.
Absolutely. Thank you, Mel. Next slide, Leanne. Okay, so lastly, I would like to talk about the participant dashboard. So there are many uses of the participant dashboard, but it can also be used, I use it, to validate my data. And so it's useful in that I can, again, select a time period, maybe focus on specific procedures or select all procedures and age groups. And then also here's one filter where I can actually select index or non-index cases and not just op types 1 and 2. So it makes this, you know, quite robust to use. Next slide. So when you look at this report, it has multiple reports within it down the left-hand side, and it's really the sections of your data collection form. So under administrative data or demographics reports, two things I like to use that for are I can identify quickly if I have sex at birth entered as ambiguous. If you don't have male or female entered as your sex at birth, you will be left out of the model analysis. So if you have ambiguous entered, you want to update that. I think probably now in the era of genetic testing and all that can be done, that I know at birth, perhaps you have ambiguous genitalia and that's what they're calling it. So you entered it in real time, but you probably need to go back and update that and locate your genetic data so that you can enter this as male or female. It's also an area where you can identify the total number of cases you submitted by op type and things so that you can make sure it matches what you're seeing locally. Under the discharge and readmission tab is where you can also do your mortality review. And for me, this is the most important place to go within this report, and it's where I go first before looking at sex at birth being ambiguous or the number of cases submitted. And again, I would advise you can start with your index operations, but then always go back and look at all of your operations when you're validating your data. Next. So when we're validating mortalities, there are 3 fields that are used to determine if you have an operative mortality. And believe it or not, it's not the field operative mortality, yes or no, which we all get hung up on, and we get lots of questions to the core group about, but that field is actually not used. The database, upon analysis, doesn't need us to tell them if a patient represents an operative mortality or not. And that's because if we're doing our jobs as data managers and answering the 3 fields that are used to determine mortality, then DCRI can take this and say, yep, this is an operative mortality or this is not an operative mortality. So these 3 fields are mortality status at hospital discharge, mortality status at database discharge, mortality status at 30 days after the last cardiovascular surgical operation of the episode of care. This is really important. So it's not 30 days after the index operation, but it's 30 days after the last cardiovascular, and cardiovascular being defined as CPV cardiovascular or no CPV cardiovascular surgical operation of the episode of care. And I have a great story for how I learned this one the hard way. But this is what DCRI is going to use to determine if your patient does meet the definition of being an operative mortality. This is all laid out again in your CHSD analysis overview under fields used for mortality calculation. Next. So when you go into then the participant dashboard, so this is your unadjusted dashboard report, you will see that under discharge readmission, you can see all three of those fields, and they will give you the number of patients, number of cases that are alive, dead, and missing. So I like to dump all of these into Excel. And then of course, when I can put all the tables together, I then have participant IDs patient IDs and event operative IDs that I can work with. But I go back through Excel, I then go back into my EHR and I validate each of these. Was this patient actually dead at hospital discharge? Was this patient dead at database discharge? Was this patient dead at 30 days. If you accidentally mark one of these as dead, you can bet that DCRI doesn't know it was accidental, and they're going to say, well, then this is an operative mortality. And so again, you don't want to do 4 years of mortalities 3 weeks before the end of harvest. So this is something you want to do in regular intervals and making sure that these fields are correct. So I keep a running log of who is dead at hospital discharge, who is dead at database discharge, and who is dead at 30 days. So that, kind of monthly, I can go and check these and make sure. So it's no surprise then when I upload something into IQVIA and I see how many are alive and how many are dead, it should match my local numbers. And so right now before harvest, I have a few patients that I still need to look at that have recently died. But otherwise, I already know from 2018, 19, and 20 that those are all complete because I've done this check as I go along and I can just quickly look at the numbers. But I go back through each of these cases, looking at their pre-op factors, looking at their complications, looking at indeed that they were dead at 30 days or not. Or at hospital discharge status or at database discharge. And so always validating. It is very easy within your software to accidentally, sometimes the way our software works and we're scrolling quickly or tabbing through the file, you accidentally hit dead instead of alive. And so this is a great way to catch that and go, why on earth did I mark this patient dead? They are clearly alive and they were seen yesterday at my facility. So again, you have to look at all three of these, because if any one of these is marked as dead, it will count as an operative mortality. Next slide. Okay, so just to sum up some successful tips, as I've said, as we've gone along, do not wait until the end of harvest to clean up a 4-year data file. And you don't want to wait until the end of harvest to identify perhaps an error in your software or something you need to work on with your vendor. And so if you're doing this as you go in your organized, consistent approach, then you will have less to do. There's less of a panic going into harvest when you've been working all along to be organized. And of course, just remember after you revalidate your data, or you need to revalidate your data after you've changed it locally and then re-uploaded it into IQVIA. You want to make sure that if you always had, say, 10 mortalities in your 4-year time period, that after you've re-uploaded data, that again, you still have 10 mortalities in your 4-year time period, just in case something you uploaded, you created a new error. And so before I'm done kind of on that last day, before harvest is due. So for me, this will probably be April 7th. I go back through IQVIA to say, yes, I know I have this much missing. I know I have, these many 30-day mortalities that are missing, or this many database discharge mortalities that are missing. I expect my missing percentage to be around this, or I know that I don't, that I have a couple of fields missing in the missing variable report. I shouldn't have any primary procedure mismatches because I should have cleaned that up. So you kind of know right there at the end. And so always revalidate before you sign off. All of us have horror stories about not doing that. And so if that's one lesson you learn from this, that's probably the best thing I can pass along. So I'm happy to take questions, although I think other people want to get in and have a few things to say. So if we could do that, and then we can jump on the questions, Leanne.
Good. Thanks, Chastity. Great review. That was extremely helpful. All right, Joe, I'm going to turn things over to you for our IQVIA updates.
I'm actually going to turn things over to Melanie for today.
Oh, it's Melanie's got the floor today. Welcome back, Mel.
Yeah,
Welcome back.
welcome back. All right, we'll get through these quickly. I know we have more updates. So in regards to upcoming report enhancements, we do have a targeted release that's scheduled for March the 26th. And that is going to be for the CHSD primary procedure report. We're currently in the UAT review. We have active data managers providing feedback related to these updates. So let me just review these. It's starting off with 7662. Leanne, there you go. Thanks.
Sorry about that.
No worries. 7662. We have an update that will be implemented regarding the priority of transplants when done in conjunction with Rule 1 exception codes. Next is 7666. And please let me just note that these updates are included in the analysis overview that Leanne also at the top of the webinar had indicated that the analysis overview has been updated. So that information is there. Also, the determination documentation that's posted on the STS website. And also we have a link to that same document from the library. So we wanted to make sure that you have the updated information available. Next is 7666. Its report will be updated to include a new rule that will address PVR procedures. Then we have 7667. The report is updating to include the new stat codes on the report. So changes to the stat codes, categories, and scores have been also updated. We will be providing that updated table once the report is released. Okay, so again, the weekend of the 26th, we're going to be doing that deployment and it will be available on March the 28th. Okay, and then we have STS 7849. We do have a new rule related to the Glenn or Hemi-Fontan procedures. Next slide. Okay, and two additional items that will be included on the report. We have 7678 related to the VSD repair patch as primary, to make sure that we consider that as the primary when the report identifies a tie with the PFO primary closure when done in conjunction with a valvoplasty tricuspid. There are also some other considerations that are being done with this effort. We will, of course, clarify that in the release notes related to the report, so we can add the additional clarity. Then the very last item is 7837. We do have a new rule that will be implemented for the conduit placement RV to PA procedures. And I believe that's the last for primary procedure. We do have upcoming updates related to the risk-adjusted report. We do have the full list available in the library. There's a document posted for the February-March 2022 issues and updates. So that list can be accessed now in the library. Okay, and those changes are related to calculation updates on the report. Okay, and I want to say we have our general slide in regards to submitted tickets are, of course, under review, and the IQVIA support team will be following up with resolutions and target release information. And of course, we are continuing to review those items, and any updates we will post to the notification section in the platform. And I think that's the last of it.
That's it. Great. Thank you, Melanie.
Thank you.
And of course, standard slides you all are familiar with. Once the reports are released, and again, we'll send a formal communication once the fall 2021 reports are available. Questions for any reports, previous and future, please direct those to CHSD tech support at IQVIA.com, and then STS and DCRI will be looked in as needed. Oops, excuse me. My contact information, you're always free to reach out to me with any questions or concerns. I do welcome all your feedback, and I'm here to listen to you. if you have any questions or concerns. If you have database operational questions regarding contracts, contacts listed for your site, access to the platform, please reach out to us at stsdb@sts.org. And then here is a list of our upcoming webinars. Our next monthly webinar is scheduled for April 19th. And then our next upgrade webinars are scheduled for March 22nd, April 5th, and April the 12th. So that's all we have. I know we have several questions and we're running a little low on time, but let's go ahead and tackle some questions that we have. Our first question from Heather, can you please repost the slide of the IQVIA update slide for this harvest April 8th? I'm not sure. I'm not sure.
Is it just the harvest dates like back at
Is
the
it just
beginning?
this?
Yeah. Is it that?
I'm not sure. Yeah, I'm not sure if this is what you're talking about, Heather. But also this, as always, this webinar will be recorded and these slides will be in PDF formats and will be posted on the STS website as well. So I hope that's what you need. If not, just let me know. My next question from Krista is participant exclusion 2% missing for each individual year or the 4 years overall? So the participant and the percent missing threshold, the 2% threshold is for each individual year. So you must meet the 2% threshold for each individual year in order to get to be eligible for the star or composite. So we are looking at each individual year. 2% threshold must be met for each individual year. And again, if you're missing more than 2% for any one of those years, then you are excluded. Chastity, can you repeat where you found the missing percentages report within IQVIA?
Oh yes, that it's in the mortality eligibility summary report. I think it's listed on one of the slides, but I believe it's called mortality eligibility summary report. And yep,
that's right here.
Yep. And so it's with your primary procedure mismatch report. And so what you have to do is scroll all the way down to the bottom. There are 2 tabs. One tab is your primary procedure mismatch report. The other tab is your mortality eligibility summary report. So you have to know to tab to the second one.
Yes, perfect. Thank you. All right. I think Dr. Subramanian wants to tackle this question. My surgeon does PA plasty with all valves, but wants the valve as the primary. STS wants the plasty to be primary. Dr. Subramanian?
Kathy, this is a good question. Just to clarify, I'm assuming you're talking about pulmonary valves. So we actually tackled this in one of the primary procedure changes that was made for this upcoming harvest. Melanie touched on it a little bit. It is in the email that went to the surgeons and the participants. It's also there in one of the webinar calls that Chastity did before. The new changes as follows. If you use one of the codes 2270 or 600, which are pulmonary valvuloplasty followed by replacement or pulmonary valve replacement, and along with that, you also code 530, which is the main PA plasty code, PA reconstruction plasty main trunk. If you code that together, moving forward, STS will use 2270 or 600, which is the pulmonary valve codes as the primary. It will not use the main PA plasty code, even though the main PA plasty code has a higher stat score. But remember, this is only for main PA plasty. This is not for branch PA plasties. If the surgeon does additional branch PA plasties and uses different codes and they happen to have a higher stat score, they will become the primary procedure. Hope that's clear. Back to you, Leanne.
Great, thank you so very much. Our next question, I think Melanie's already covered this. When will the primary procedure mismatches with the new stat scores be applied? And again, they will be applied. The new stat scores will be coming out March 26th. Correct, Melanie?
Yeah, we're deploying the 26th,
and
it'll be available on the 28th, which is a Monday.
Yeah. And then also, as Melanie stated, the updated Appendix C that you all use will also be available within the IQVIA library, and I think it's also posted on the STS website as well. So at that time. And Chastity, I think this is actually a question related to our upgrade webinars. I don't know if you want to tackle here, if you would prefer to tackle on our next upgrade webinar.
For the new 6.22 fetal interventions, we are told to use the mother's MRN with fetal appended to it. Is MRN all we should use, or do we use the rest of the mother's demographic information as well? I believe the answer here is that you won't fill out a lot of that demographic information. There's just a few fields that you will complete for these fetal interventions. So it's just the MRN with fetal attached.
All right. Dr. Subramanian, I don't see any other questions. I don't know if you had anything you wanted to address regarding the upcoming surgeon webinar or anything you wanted to share with the group. Oh, are you on mute? Or did he step away? I think he's on mute. All right. Kathy, should we attend the surgeon webinar or will it be repeated information? You're welcome to attend the surgeon webinar. It's open to everyone. I think mainly if, Dr. Subramanian and Drs. Nelson will be covering, what we have covered in the upgrade webinars. Again, it will be geared a little bit more towards the surgeons, but you all are welcome to attend. And again, it will be recorded. So again, you're welcome to attend. But I think Dr. Subramanian must have stepped away or is unavailable right now, so I apologize. The overall analysis overview states that we know more than 2% missing for the overall analysis population. Can you please clarify? Heather, I will look into that. I want to, it's each year. You must meet the 2% threshold for each year. So let me review that and let me, I think I need to make an update to the overview, so I apologize for that. So let me go back and review and I will clarify that in the analysis overview. But again, you must meet the 2% threshold for each year. I had some anesthesia fields show up as missing on the DQR and show as errors. IQVIA told me that they are fields required by STS. I submitted an FAQ about this, but I haven't heard back. Is there a change that anesthesia fields are now required? Chastity, did you want to tackle this one or?
Sure, I can't speak specifically to what is showing up in your errors from IQVIA, but what I would say is all fields in the database are considered required. Not all fields touch the analysis buckets or analysis reports the same, but all fields are required. So they are going to show up in missing and things like that, but it will not go, not all of them would count against you. So I don't think that there's any anesthesia fields that if they were missing, they would preclude you from being in the analysis currently.
Correct. Our next question from Beth. Excuse me. I think I misunderstood something. Can you go back over the 30-day mortality determination again? I thought we marked it as it pertains to each operation. Does her question make sense?
Yes, Beth, your question does make sense. And so yes, after each procedure that's done, you would answer at 30 days is the patient alive or dead? What this is saying, when I brought up the fields that are used to determine mortality, I think it's
the validated mortality. So is this what this slide?
And so when you look at the fields, it's the one where it's 30 days from a cardiac operation, the last cardiac operation, and so I know that that's where people get hung up. And so let me share my story and then perhaps this will help you. So we had a patient that had an index operation. They stayed in the hospital for 6 or 8 months. Right before they went home, we threw a pacemaker in the patient, which is op type, no CPB, cardiovascular. The patient went home 3 days later, ultimately died at home, a few days later. So I'm thinking this patient is well out from their 30-day mortality from their index operation. However, it showed up in my analysis report and I felt like I got cheated. And so I call STS and I'm like, wait a minute, this patient was alive for 9 months following their index operation and they even went home. How is this counted as an operative mortality? And that's where I missed it. It's 30 days after a cardiac operation. And so not just 30 days from the index operation, but 30 days from a cardiac operation during the episode of care. So my patient right before they went home, had a pacemaker procedure, no CPB cardiovascular, and at 30 days they were dead. So that then counted as an operative mortality. And so, yes, you're filling it out for each surgery, but upon analysis, if they die, if that last surgery, in my example, the patient had had an ECMO procedure, that would not be included to say the patient had died. But because the patient had a no CPB or CPB cardiovascular procedure, it would go into the mortality determination. So that's why the phrasing of that is a little bit different.
Thank you, Melanie. Goodness, Chastity.
It can be Melanie.
I want to be Melanie.
Is Dr. Subramanian available? I know he wanted to say a few things.
I know. I just sent him a chat. Yes, there he is, Dr. Subramanian.
Yeah, thank you. I just want to take a couple of minutes to quickly talk about the 6.22, the new data collection form upgrade. So the data managers hear it. I know Chastity's been doing an incredible job, going through the new data collection form and trying to explain to you all the changes that are going on. I want to assure all of you that we understand the apprehensions that you all have. The database task force really does. The STS leadership really does. We're not going to push anything through until it's all ready. So as Leanne pointed out in the beginning, we are discussing when we would be able to do this upgrade in the correct fashion, trying to fix all the errors to the best extent possible and release a data collection form version that's useful and accurate to all our participants. So we're not wedded, even though we're trying our level best to release it as quickly as possible. We're not wedded to the July 1, 2022 date. We're considering all options, discussing with you all, the data managers, with our surgeon participants, with our vendors, and with IQVIA to make a decision. I will discuss this in the task force call that's coming up. Like Leanne said, we're not going to push this down. So I just want to take the anxiety level down. And another important point, which is particularly relevant to the data managers, is that remember, all the additional fields that have come up for the adult congenital patients will only open up for patients who are entered into the congenital database whose age is calculated to be over 18 years only, which means for the majority of patients that you're going to be operating on, you will not have any of these new fields. In contrast, many of the old fields, which were very data burden heavy, such as blood transfusions and so on and so forth, have all been eliminated in the new data collection form. So the net sum, if you do the math, I'm very confident telling you that the data burden for the vast majority of your patients is actually going to go down. For those programs that tend to enter a greater number of patients who are over 18 years of age in the congenital database, you will have additional data fields only for those patients. But remember, only those data fields that are relevant to the procedure that that patient is undergoing. If, for example, we're putting a pulmonary valve in a 24-year-old patient, you're not going to have to open up all the aorta fields and all the aortic valve fields and the VAD fields and so forth. We have very deliberately established parent-child relationships to restrict the additional fields that you will need to fill up for specific patients. I say this because on the face of it, it may look like, oh, suddenly there are so many of these adult data fields that have come into the congenital database. Remember, they are only for patients over 18 years of age entered into the congenital database, and there is significant parent-child relationships which will restrict the number of additional fields you will need to go through. So I understand the anxiety. We really do. We hear you. We're not going to do something that makes the data manager's life any more burdensome. I've said it before, and I continue to say that data managers are the core of our database. We want to make sure your concerns are heard, and we want to make sure we make a data collection form that is easy for you to navigate through and fill. So thank you for everything you do, and stay tuned. We will give you more information on when the data collection form rollout will happen. Thanks. Back to you, Leanne.
Excellent. Thank you so much. I think actually we are at the end of the hour. I know others have other calls to get to and other meetings to attend. Thank you so much, Dr. Subramanian, for being on these calls. We greatly appreciate it, and we appreciate your leadership and your thoughts. And again, just thank you very much. Thanks everyone from the IQVIA side, STS side. I appreciate it. I hope you all have a great week. And again, if you have any questions, please don't hesitate to reach out to me. As Chastity said earlier, you have questions with the upcoming harvest close, please reach out to Chastity, Leslie, myself, IQVIA tech support. We're here to help you and make your lives a little bit easier. Again, just feel free to reach out. We're here to help. Note the next upcoming webinars, our next monthly is April 19th, and our next upgrade webinars are March 22nd, April 5th, and April 12th. So with that, I hope you all have a great rest of the week. Happy St. Patrick's Day, and have a great week, and we'll see you back here on March the 22nd. Thank you, everyone. I hope you have a great week, and until next time, thank you.